Hi, good evening, everyone. So, I hope you all have enjoyed this 2 week of labs that we had in our classes. And I was not able to upload good videos because my laptop was not working. I had to eventually buy a new laptop so that I could start making these videos again. And after a break of around 2 weeks, I hope now that we can get back on the wagon and start our discussion on drugs in dermatology. And first of all, credit should be given where credit is due. So this resumption of classes would not have been possible without my brother. So just if you are seeing this video, make sure you thank him. So without further ado, we'll start this week's discussion and we'll continue our drugs for leprosy. And this time, the fourth lecture would be on thalidomide in dermatology. Now, just a little bit of background on thalidomide. It's one of the most controversial drugs, or rather, the most controversial drugs in dermatology, or rather, in all of medical science, if I may say so. Now, this drug was initially introduced as a very good antiemetic and a good sedative and a good antiemetic, but even a single 100 milligram dose can lead to significant and disturbing or organ deformities in newborn, and because of that this drug was banned. But the reason that we are discussing thalidomide this week with this lecture is because it's one of the best acting drugs in leprosy reactions. Additionally to that, in many of different kind of disorders, it is found to be significantly effective. And in the end, if you reach the end of this lecture, I will share one anecdote where thalidomide actually helped me in treating a disorder which was not leprosy. Okay, so without much further ado, we will start with the lecture. Now, thalidomide was initially introduced in Europe in 1950s, and the major action was that it was used as a sedative, a sleep-inducing drug with minimal to no adverse events. So, minimal to no side effects were seen with thalidomide, and it was a very good sedative. And because of that, it was started as a drug to induce sleep in patients. And in fact, doctors were given free samples of thalidomide so that they can be distributed to patients who are having trouble sleeping. It had minimal side effects, no adverse event as such, so it was one of the most famous drugs to start acting as a sedative. However, in 1961, this deformity or phocomelia, it is essentially a underdevelopment or non-development of limbs in fetus, in baby. So that is what phocomelia is. So in 1961, the connection between thalidomide exposure during pregnancy and development of phocomelia in babies was made concrete, and because of that, in 1961, because thalidomide was causing teratogenicity, the drug was withdrawn from the market. Essentially, it was wiped out from the market because of this severe and serious side effect of phocomelia. However, in 1965, a doctor by the name of Shiskin, Sheskin, demonstrated the significant benefit of using thalidomide in ENL. And if you go and search in PubMed, you will find a lot of articles written by Shiskin on the usage of thalidomide in different types of lepra reaction. And however, it took nearly 30 years, more than 30 years for FDA to approve thalidomide for ENL. Okay, so thalidomide started as a sedative drug, graduated as an antiemetic drug to be given in pregnant ladies for managing morning sickness, led to teratogenicity and phocomelia, withdrawn in 1961. 1965, Shiskin comes and says that it is one of the best acting drug in ENL, but still it took more than 30 years for FDA to approve thalidomide for ENL. Okay, so let's move forward. In the structure of thalidomide, it's a non-polar glutamic acid derivative. Okay, the class that it belongs to is known as piperidinidione hypnotic. As we said that it was initially a sedative. Okay, so piperidinidione hypnotic is a class of drug in which we have thalidomide. So it has two different areas. So on right side you will have a glutamide ring, and the left side you will have a thalidomide ring. So because of thalidomide, the name thalidomide comes. Okay. So if you see the structure, thalidomide. Okay, so that's how thalidomide name comes. Plus you have a asymmetrical carbon at this point. Okay. So this hydrogen which is attached, depending if the hydrogen is out of the plane or into the plane, you have two isomeric forms, the S form and the R form. Okay. And because of this asymmetrical carbon, these two isoforms exist, and one isoform is sedative, the other isoform is responsible for teratogenicity. And in vivo, inside the body, there is rapid conversion. There's rapid conversion between the two isomeric forms. So R isoform and S isoform are rapidly converted among each other in vivo. Okay. So here we can see the R plus thalidomide, which acts as a sedative. So it will be a bit difficult for you to remember, but R is S. So R is sedative, S is teratogenic. Okay. So you can see here the hydrogen is jutting out of the plane, and here the hydrogen is going into the plane. Okay. So S form is teratogenic and R form is sedative, and there is rapid interconversion at physiological pH. Let's understand pharmacology for thalidomide. It's a drug which is available to be administered orally only. There are no IV preparations, only oral tablets are available for thalidomide. There is no difference with meals. That means food does not change the absorption of thalidomide. The bioavailability ranges from 67% to 93%, but these are only animal studies. Okay, so human studies are lacking, but bioavailability through oral route ranges from 67% to 93%. Peak plasma level occurs within 2 to 6 hours. It rapidly crosses the placenta membrane because of its significant lipid solubility. Okay, this drug is highly lipid soluble. It's a non-polar molecule. We are discussing the structure slide, and this non-polarity leads to high lipid solubility, and because of that, it can rapidly cross the placenta and reach the baby. And when the organogenesis or organ development is going on inside the fetus, it causes issues with the organ development, and the limbs are not able to develop properly, leading to Phocomelia. Clear? The metabolism occurs because of non-enzymatic hydrolysis of thalidomide. That means inherently, by its inherent nature, it gets converted into degraded products, and those degraded products are then excreted out of the body. There are at least 12 cleavage products that have been studied, and these 12 cleavage products also have anti-inflammatory and in fact even sedative and other properties of thalidomide. So when thalidomide gets cleaved into 12 different cleavage products, or these are not 12 parts, they are 12 different kind of cleavage modifications of thalidomide. They also have their inherent pharmacological activity as thalidomide. Now half-life is 9 hours. This is a good Viva question, so you should remember that thalidomide half-life is roughly about 9 hours. So let's read about the mechanism of action of thalidomide. And one thing that you have to keep in mind, let me just adjust the camera a bit. Yeah. One thing that you have to keep in mind is that largely the mechanism of action of thalidomide is not entirely known. It relays its effect to multiple different type of mechanisms, which we will study a little bit in details in subsequent slides. But the mechanism of action for thalidomide has been described under 3 major headings. The hypnosedative effects. Remember that it was a sedative. Thalidomide was a sedative before, at the time of introduction. So it has hypnosedative effects. Immunomodulatory and anti-inflammatory effects. These are the major effects which is used in ENL as an immunomodulatory and immunoregulatory effects of thalidomide. Okay. The neural and vascular tissue effects. Now, neural effect is significantly used in cases of let's say pruritic dermatosis like prurigo nodularis, maybe EB pruriginosa, EB pruriginosa. So disorders which are associated with significant itching, intractable pruritus, intractable itching, you have this neural mechanism action. Clear? So three major classes: hypnosedative, immunomodulatory, and anti-inflammatory, neural and vascular. Clear? Let's move forward. In hypnosedative effects, thalidomide rapidly penetrates central nervous system. It crosses the blood-brain barrier, rapidly gets inside the brain, acts. Now remember that why it's penetrating the membrane. It is a glutamide, analog or a structure similar to glutamide. So that molecule is easily able to cross the blood-brain barrier, attach itself to receptors, and cause a somewhat inhibition of central nervous system, causing sedation. Okay, this sedative effect is comparable with barbiturates. It is of the same intensity as if you are giving a barbiturate. Sedative. Let me just write it again. That's not correct English. The efficacy is nearly the same as you have used a barbiturate. So the sedative effectiveness of thalidomide is comparable with usage of barbiturates. The CNS toxicity is rare. Okay, so if you remember that whenever you prescribe thalidomide in your patients of leprosy or Hansen's or with ENL, they might complain of drowsiness, dizziness, increased sleepiness, somewhat lethargy. That's because it is having a sedative effect of thalidomide. However, the toxicity is rare. Okay, and this sedation is also, along with the neural effects, this sedation is effective in the treatment of pruritic condition like PN, prurigo nodularis, or actinic prurigo. So this kind of inhibition, this central nervous system inhibition, and as an extension of thalidomide, the peripheral nervous system inhibition significantly helps in you could say suppressing the itch stimulus in pruritic conditions like prurigo nodularis and actinic prurigo. Okay. Now, this is the most important mechanism of action of thalidomide, and it's one of the most important mechanism which is responsible for its efficacy in ENL, and it is very important for us to understand how it acts. Fortunately, the immunomodulatory effects are not clearly known. How thalidomide acts as an immunoregulator molecule, that entirely is not known, but it's easier to remember few salient points. For example, if you get a short note on writing, let's say a viva question on what is thalidomide, how does it act, at least you will be able to answer something. So the most important is TNF alpha inhibition. So if you have been following our video lectures and if you have seen the lecture on pathomechanism of psoriasis, you would remember that TNF alpha is one of the central cytokine mediated for inflammation. So TNF alpha leads to inflammation. Okay. So if you inhibit TNF alpha, you inhibit inflammation. Clear? So thalidomide leads to TNF inhibition, interleukin 12 suppression, interleukin 4 and 5 production. This is somewhat of a paradoxical mechanism that it increases 4 and 5. 4 and 5 is much more important for IgE mediated or atopic dermatitis disorders, but we'll discuss them in the future if any specific video is made. So interleukin 4 and 5 production is increased by thalidomide. So that's why let me just remove this so that we remember that this is a paradoxical reaction. Apart from that, interferon gamma, that is also important inflammatory cytokine. If you have any, if you want to know how TNF alpha or interferon gamma leads to inflammation, I would request you to go back, search for the video lecture on pathomechanism or etiopathogenesis of psoriasis and go through that video, and you'll be able to understand the inflammatory cascade that TNF alpha leads to, and then you'll be able to understand how thalidomide is helping in managing that inflammatory issues in ENL. Okay. It reduces the polymorphonuclear cells, the monocyte phagocytosis and chemotaxis. That means it reduces the migration of these inflammatory cells to the site of action. Clear? Other mediators like histamine, acetylcholine, prostaglandins, serotonin, it inhibits it. So any histaminergic itch, it helps in decreasing that itch. Acetylcholine, prostaglandins, serotonin, these are all secondary mediators of itch, secondary mediators of irritation. So thalidomide actually helps. Let me just adjust the camera a bit more. Yeah, so thalidomide actually helps in decreasing this kind of inflammatory mediators, causing significant improvement in itch-mediated disorders. So this slide becomes very much important. If you want, I'll just remove the yeah, I'll just remove everything so that you can take a screenshot or something. That these are the pointers that you will have to keep in mind while discussing the inflammatory cascade or the inflammatory inhibition by thalidomide. And you can easily answer any of your Viva questions. Clear? Let's move forward. The mechanism of action as per its action on nerves and vessels, it is only just to take care of peripheral neuropathy. Now, peripheral neuropathy is very important side effect of thalidomide. Okay, majorly sensory neuropathy, to some extent motor also, but majorly sensory neuropathy. The peripheral neuropathy is one of the major side effects that you have to look for in your patients of Hansen's who are receiving thalidomide. Okay. The mechanism of action in angiogenesis, that means formation of new blood vessels. For example, it inhibits the formation of newer blood vessels. So remember, if you remember your Robbins second year MBBS chapter of neoplasia, development of a vascular architecture is important for malignant transformation, or not even malignant, basically cancer formation. So if you inhibit the vascular formation, you will have decrease in formation of cancer or decrease in formation of neoplastic tissue, and that mechanism is being explored in cancer studies so that we can have one more drug to decrease the angiogenesis in neoplasia. Clear? Let's move forward. Now quickly we're going to discuss the uses of thalidomide quickly, because we don't use it as as varied as other drugs. The indications are somewhat limited to inflammatory disorders, that is off-label indications. So we'll just enumerate and discuss. Okay, so US FDA has approved thalidomide for only use in ENL, erythema nodosum leprosum. And remember one point to clarify, that WHO doesn't label it as a drug of choice for ENL. It is still corticosteroids because of its issue with side effects, issue with Phocomelia, and so that people don't abuse it. And since WHO is supposed to be a mediator for the whole world, it cannot just give a good impression if it grants the approval for use in ENL, if it grants approval for thalidomide. But FDA has no such issues. FDA has seen the efficacy of thalidomide. However, it took 32 years, but it saw the efficacy and it has granted FDA approval for thalidomide to be used in ENL. Clear? Now, other dermatological disorders. It's my pointer. Now, again, like we used to do, we'll just have to remember the heading. So, HIV-related dermatosis, neutrophilic dermatosis, vesicobullous dermatosis, lymphocytic infiltrate, other dermatosis. Okay. So, how to remember this? HIV-related dermatosis. It has been found that because of immunomodulatory action, the AIDS-associated oral stomatitis and AIDS-related Kaposi sarcoma, these are off-label use of thalidomide in HIV positive or retropositive patients. Now, as we have said that it decreases the migration of neutrophils. Okay, so it can be used in neutrophilic disorders like giant aphthous stomatitis. That means such large stomatitis, such large aphthous ulcers that you need a bit of a stronger drug like thalidomide. It has been approved to be used in Behçet's disease, predominantly the oral ulcers of Behçet's disease. Okay. Pyoderma gangrenosum and neutrophilic migration mediated disorders. You stop migrating neutrophils, you will help in decreasing the inflammatory activity in pyoderma gangrenosum. Vesicobullous dermatosis like erosive lichen planus, bullum pemphigoid, cicatricial pemphigoid, recurrent erythema multiforme. So these are some indications of using thalidomide. Lymphocytic infiltrate. Now lymphocytic infiltrate, for example, cutaneous features in LE, Jesner's cutaneous lymphoid hyperplasia, wherever the lymphocytes are coming in contact with skin and accumulating there, thalidomide can be used. Other dermatoses include chronic GVHD. Prurigo nodularis is very important because that's the most common non-Hansen indication in my opinion. Sarcoidosis, Langerhans cells, anywhere where the inflammatory cells are accumulating. Post-herpetic neuralgia, we have a lot of patients who deal with, who have to suffer from post-herpetic neuralgia, uremic pruritus. Now these are the important indication for, off-label indications for thalidomide. Now let's discuss the use in leprosy, and this will be, I think, the only one slide, because the indications are somewhat described how to use thalidomide in leprosy. If you want, you can go and read the WHO guidelines. It does mention how to use thalidomide. It just has not given it a approval status. So we have talked about the Dr. Sheepskin, who was responsible for reintroducing thalidomide in one of its most effective uses, that is in Hansen's. Now these are two good articles that I read about read about thalidomide written by Sheepskin, and I will mention this citation in the description. So if you want, you can copy paste and go and read these articles. These are very old article. This is from 1965, in which it introduces thalidomide in the treatment of lepra reactions. Okay, and the other article is 1975, thalidomide in lepra reaction. The full text is available on PubMed. Go and read this. You will easily understand how somewhat of a path breaking it was to reintroduce a drug which got swept away in the market nearly 4 years back. So you had to reintroduce it. These are very good collection of articles on the use of thalidomide in leprosy and various other indications, but written by Sheepskin. So it's a good idea to go and read. It is used in type 2 reaction. The efficacy is not that good in type 1 reaction. So ENL is what we are looking for. Type 2 reaction is ENL. Onset is very quick, in 1 to 2 days. Okay. So best way to start and use thalidomide is to start it as 100 mg 3 to 4 times a day, and then attempt to discontinue as soon as possible. So they usually say that you start at 100 milligram 4 times a day, and as soon as ENL is controlled, you start tapering by, for example, you will start tapering to TDS dose in 2 weeks, BD dose in a week, OD dose in a week, and then stop. Okay, and all the time you can combine this thalidomide with corticosteroids. Remember that corticosteroids are mainstay of treatment. All other drugs that we use to manage type 2 reaction is just to take care of side effects that the steroids cause. Okay, so steroids are the most effective drugs to control lepra reactions. The only issue is their side effects, and to circumvent those side effects, we use the other types of drugs like thalidomide and everything else. Clear? So you start with 100 milligram 4 times a day and try to rapidly taper so that you are able to stop it as soon as possible. Okay. Other uses like in prurigo nodularis, the onset of action is about 2 to 4 weeks. Remission takes about 8 months. Peripheral neuropathy was seen in about 1/3 of cases as a side effect of thalidomide. Other uses like aphthous stomatitis takes around 1 month to show its good efficacy, or in fact a good resolution of aphthous stomatitis in 2 to 4 weeks. However, whenever the drug is stopped, frequent relapses were seen. Okay. Behçet's disease, the skin and mucosal involvement fares much better on thalidomide. The skin and mucosa are very much improved with thalidomide. I have seen patients of, I think, 3 or 4 patients which we had given thalidomide with significant improvement. But the eyes, the uveitis aspect is not that responsive to thalidomide. Vesicobular dermatitis, this should not be okay. So vesicobular dermatosis, for example, your bullous pemphigoid, cicatricial pemphigoid, okay, maybe pemphigus vulgaris too. So you can have thalidomide if all the other drugs are you're not able to use it. Okay. Now contraindication. Absolute contraindication. Absolute contraindication for me is sensitivity to thalidomide, like any drug reactions. Okay. And pregnancy. Pregnancy is a strict no, 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 no. Do not even think of using thalidomide in patients who might be pregnant. Okay, trust me, all lepra reactions can be controlled without thalidomide, and no indication, no severity of lepra reaction justifies the development of Phocomelia or other side effects or other adverse events in the fetus. Okay, remember that thalidomide affects all organs of the body. Okay, so no indication of thalidomide can justify it to be given in a pregnant lady. The female has to be having a non-pregnant status for us to even consider thalidomide. Clear? And one more. Okay, we'll discuss this aspect when we'll be discussing Phocomelia. Okay. Patients with existing peripheral neuropathy. Remember that peripheral neuropathy is a very important side effect of thalidomide. So if they already have peripheral neuropathy, you don't give thalidomide. Now, even in males who have a significant partner or who are planning for pregnancy, we should avoid them because the thalidomide has also been found in seminal fluid. Okay, so it's important that that kind of exposure is limited. So even if you have a male patient, they are not necessarily you know um, saved from thalidomide side effects. The thalidomide drug can easily be transmitted to the female. Okay, so make sure that you don't give it to patients who are actively seeking pregnancy. Okay, with their partner, of course. Relative contraindications with significant hepatic or renal impairment. So you're not supposed to give thalidomide because any drug is going to go through these two organs. Patient with history of neuritis or other neurological disorder because it has a CNS depressing effect. It also has neuropathy as a side effect, so we need to be sure. Congestive heart failure or hypertension, constipation or hypothyroidism. This is all because of side effects of thalidomide. It's a category X drug. Remember category X. Okay, so that is important to remember. However, this is the older category. The newer category is absolutely contraindicated pregnancy. Okay, let's move forward. So here we're going to discuss in 2 or 3 slides the teratogenicity because that is the most important and the most disturbing side effect of thalidomide. There are two drugs, thalidomide and retinoids, who are teratogenic and we routinely use them. So we have to be very clear about what are the side effects so that we are able to counsel our patients to avoid these side effects. Sometimes, let's say what happens is, let's say you have one patient of leprosy in ENL, male patient not seeking pregnancy with their partners, and you give thalidomide with significant control of ENL, and somebody else in their locality, in their neighborhood, who also has leprosy, develops an ENL reaction, they're going to give thalidomide to that person also. And if that person happens to be a female or happens to be a pregnant female, you now have a Phocomelia child on your hands. Okay, so make sure we are able to convey the safety or convey the side effects that we have to keep in mind while giving thalidomide to our patients. Clear? So the mechanism of teratogenicity because of thalidomide is unknown. There are multiple things. Some say sonic hedgehog protein, expression. Some say the homeobox protein expression. Some say there's one more. I'm not able to remember the protein, but that is responsible for left and right development of the body. The genes which are encoded or the secondary messengers which are necessary for development of limbs, those get suppressed by thalidomide, but these are all theories. We are still looking for some concrete evidence. So mechanism is not known. Isn't it very easy? Okay, when mechanism is unknown, do you think it makes it easier for us or makes it tougher for us? Now, it has been reported that the drug's affinity for nerve tissue and the suppression of angiogenesis, which we have discussed in the uses, is somewhat responsible for these kind of side effects. Now, the peak vulnerability is from day 21 to day 36 of gestation. That's where the maximum organ development starts. and a single 100 milligram dose is enough to cause 100% incidence of birth defects. This is, I think, the most important line for thalidomide side effects. A single 100 milligram dose of thalidomide causes 100% incidence of birth defects. Now, the next question that you might be thinking about is that what happens if I give 50 milligram thalidomide? Can I manage my patient on 50 milligram thalidomide? Please, again, I repeat, no amount of lepra reaction is an indication to give thalidomide in a pregnant female. Okay, instead give steroids, handle side effects. But in thalidomide, even if a single molecule or even if a slide is transmitted to the fetus, and we know that thalidomide freely crosses the placenta, we should not take that risk. Okay. Most common teratogenic effect is known as phocomelia. In the next slide, I'll show you a picture of phocomelia so that you may remember what phocomelia actually is. Okay. So this is a phocomelic child. However, in this child, the upper arms are affected. The lower limbs look okay, but if you look closely, even the lower limbs are not that properly developed. There is a shortening of lower limbs, increased curvature, and because of that, we can see that the limb formation, at least on this photograph, we can see that limb formation is severely affected. What actually happens is, let me just make this. Let's say this is the thoracic wall, and here you will have limb buds. Okay, and with time, what will happen is this limb bud is going to increase. So with time, this limb bud is going to increase, and this will form the upper limb. And then you will have the finger buds, and the hand is going to form. Now in phocomelia, the development of palm and fingers is okay. The issue happens with development of humerus, ulna and radius. And it is said that it affects the thalidomide. Thalidomide affects humerus first, then it affects radius, and in the last it affects ulna. And there is shortening of the bones, and in severe cases the bones can just be absent. So what you will have is you will have a thoracic wall, and here you're going to have your hand. Like in this patient, this child, we can see that the thoracic wall ends here, and here we have just the hand directly attached to the thorax. There is no development of upper limb. Okay, and the whole life of the child is severely affected because of that. Clear? Now, I would like to recommend this documentary. It's about a 1.5 hour documentary. It is freely available on YouTube. I will also put the link to access this documentary in the description box. Just copy paste and you go to this documentary. The title of this documentary is No Limits: History's Greatest Drug Scandal. I'll have to change this here. History's greatest drug scandal, and this is because this is the documentary tells us about how thalidomide was introduced, how it was found out that phocomelia was one of the major side effects because thalidomide was given indiscriminately to patients who were pregnant, wanted to have some relief with through for a morning sickness, and they were given thalidomide as an antiemetic free of cost, and it led to a huge epidemic of children born with phocomelia and limb deformities. And this is a very good documentary. If you have time this weekend, it's freely available on YouTube. Go and see this documentary. You will understand what do we mean by the effect thalidomide had on children and why it is the history's greatest drug scandal. The scandal on thalidomide was so great that it virtually changed the drug safety standards in the US. So before that, they were somewhat lax, but after they got to know about the effect of thalidomide on newborn children, it changed the parameters on which drug safety was tested. Okay, so this is no limits, and if you remember this sign, this omega sign. This sign is for, if I remember the spelling correctly, this sign is for Grunenthal. Okay, and Grunenthal is, I think, the German company, a German company which introduced thalidomide the first, okay, and then subsequently they had to take it back, then sell this molecule, or sell the formula for this molecule to Celgene Corporation, and now Celgene manufactures thalidomide in US. Okay, so Grunenthal, this sign, this omega sign is of Grunenthal logo. Okay, so let's go forward. So Lenz and McBride were two scientists. I think one of them was I think Lenz was for England and McBride was for Australia. And these two independently made everyone know that thalidomide is the cause of Phocomelia. Okay, so they attached thalidomide to Phocomelia, and because of that, it led to a cascade of investigations. And because of that, thalidomide was banned from marketing in 1961. The banning of thalidomide because of Phocomelia is known as the largest man-made medical disaster. Again, go and watch this documentary. It's very good. Okay. Now, polydactyly is also associated with Phocomelia. That means you can have the thoracic wall and maybe 1, 2, 3, 4, 5, and 6 fingers. Okay. Sharp acromioclavicular joints. So what happens is that the shoulder joint becomes very sharp because acromioclavicular, this is your clavicle, you will not be able to see properly, but this is the clavicle, and it attaches to acromion and this, so you will find this kind of an jutting, the bone jutting out from your shoulder, and because of decreased development of the humerus, you don't have the roundedness, you have a sharp acromioclavicular joints. So these are also additional effects of thalidomide along with Phocomelia. Okay, okay. Now, additionally, is thalidomide embryopathy or thalidomide syndrome. So, Phocomelia is one aspect of fetal deformities in patients who had taken thalidomide, but additional involvement of all other organs along with Phocomelia is also known as thalidomide embryopathy or thalidomide syndrome. So, thalidomide affects all organs, upper limbs more than lower limbs, face, eyes, ears, genitalia, internal organs including heart, kidney, GIT tract, vertebral column, virtually every organs are affected. That's why I told you no amount of reaction justifies the use of thalidomide in females who are pregnant. Infant mortality ranges till 40%. Additional hypoplastic hip joint has also been reported in newborn babies whose mother had taken thalidomide. Okay. Eyes show microphthalmia, that means small eyes. Anophthalmia, that means no eye. Poor vision, no lacrimation, decreased or zero tear formation. Coloboma. So coloboma is like if you have your iris and this is your pupil. In coloboma, there is the defect which rises from the pupil to the edge of the iris. Okay, so this is coloboma. Strabismus, because the development of your extraocular muscles doesn't take place properly, so strabismus is there. Ear has anosia, microtia. Anosia means no ear, microtia means small ear, deafness means you're not able to hear it, majorly sensorineural deafness, and also because of less development of ear during the embryogenesis. CNS palsy, cranial nerve system or the central nerve, cranial nerve palsies are also reported. There's a report of facial hemangioma, which predominantly, let's say if this is the face of the baby, a very ugly looking baby, but still, it majorly impacts the central area or the forehead, and this somewhat disappears in 2 to 3 years. So facial hemangiomas have been reported, okay, and but it gradually disappears in 2 to 3 years. Irregular teeth and clefting, both cleft palate and cleft lip has been reported because of thalidomide. So remember that all organs are affected, and what are the general deformities of different organs that we have listed. Clear? Now this chart, it's a very good chart, but just to understand, it's not academically important for us as such, but it's good chart to have. So this says that post-conception, these are the post-conception number of days, and this is the post last LMP date. Okay, and because of that, we can see that whenever if thalidomide is introduced here, so external ear would be missed. If it is introduced here, then internal ear damage would be there. Microphthalmia occurs after 24 days of post-conception. Coloboma, thumb damage. So this chart just essentially tells us that when thalidomide gets introduced, depending on the day it is being introduced in the system, these kind of deformities can happen. Okay, so it's a good chart just to understand that uh, all processes of embryogenesis and organogenesis are affected because of thalidomide. Okay. Okay. So the next important side effect is peripheral neuropathy. Just a second. Yeah. Yeah. Next important side effect is peripheral neuropathy, and it starts as a mild proximal. It includes mild proximal muscle weakness and symmetric painful paresthesias of hands and feet. So the peripheries of the body is affected. The hands, feet, somewhat tingling sensation, gradually increasing to leading to painful paresthesias of hand and feet. Lower limb sensory loss have been reported. Motor weakness. If remember that I said that in peripheral neuropathy, the sensory nerve systems is affected first, but gradually it affects both types of sensations: the motor physical sensation and the sensory sensations. Okay, both of them are affected. The motor weakness recovers rapidly, but the sensory dysfunction improves slowly. So when you stop thalidomide, the motor deformities or the motor disabilities, sorry, not even disability, you would say the motor weakness, it recovers rapidly, but sensory dysfunction improves slowly, if at all. Okay, so if at all, that means the sensory dysfunction may not even improve, and even if it improves very slowly. Okay. So the peripheral neuropathy is described as axonal neuropathy. That means the damage is to the axons. Okay, and in nerve conduction studies, we see that there is reduction in snap amplitude. This is a very important viva question. Okay, so there's decreased snaps. The snap is sensory nerve action potential, but the nerve conduction velocity is spared. Okay, so if we get done NCV studies and we are looking only at nerve conduction velocities, those are somewhat, they can easily be spared, so it won't help you. But we have to look at snap amplitude, the amplitude of sensory nerve action potential, which we can easily see the decrease in snaps, which points us towards thalidomide induced peripheral neuropathy. Now, other side effects include thromboembolic events. Your risk of DVT increases, stroke increases. To just make sure that you know your patient's clinical profile without before starting thalidomide. Pool rate of around 2%. If your patient has some of these risk factors, make sure you know about them. For example, arterial thrombosis, DVT, hypercholesterolemia, active smokers, or let's say you have a female who doesn't want to get pregnant, who is very much sure of her pregnancy status, who has taken 2 3 pregnancy tests which are negative, and you want to start thalidomide, you have the consent, and patients taking OCPs as a form of contraception. Remember that OCPs can also have increased thromboembolic events, and couple that with thalidomide, you're going to increase risk. Okay. Endocrine side effects like hypothyroidism, hypo and hyperglycemia, ACTS stimulation, all can occur with thalidomide. Okay. In patients who are retropositive, it has been shown that the viral load is increased, and also the propensity or the probability of developing hypersensitivity reaction thalidomide also increases in retropositive patients. So these are just some side effects which you can easily list them out during a vivas. Drowsiness, as we know that it is a CNS suppressant. So drowsiness is a very common side effect. Mood changes, dizziness, xerostomia, brittle fingernails, leukopenia. Constipation, nausea, constipation, vomiting is for nearly all drugs. Increased appetite, couple that with steroids and your patient will become obese. Peripheral edema, xerosis. Paradoxically, it can cause pruritus also because it's causing xerosis. Okay, so it is used in disorders of pruritus when the pruritus is majorly because of inflammatory damage or neural damage. So it helps in that, but it can also cause xerosis, further leading to pruritus. Irregular menses, and this becomes important if you're tracking the pregnancy status of female who is on thalidomide. Now comes one of the most important slides, how to monitor a patient on thalidomide. And you have to remember this name, the REMS program. Okay, so it is Thalidomide REMS program for monitoring thalidomide therapy, 1999, Celgene Corporation and FDA. Now remember, I've told you that thalidomide was manufactured first by Grunenthal, then the patent got transferred to Celgene, and then Celgene and FDA together developed these guidelines. Initially, it was known as STEPS. ठीक है, sorry, step strategy. I'm sorry, switched to Hindi for some reason. Okay, so it steps is systemic, not systemic, system. Let me remember steps. System for thalidomide education and prescription safety. Okay, so steps is system for thalidomide education and prescription safety, and afterwards these steps got renamed as thalidomide REMS program. Okay, REMS program for monitoring thalidomide therapy. And what is REMS? REMS is risk evaluation and mitigation strategy. So risk evaluation and mitigation strategy means you evaluate the patient for any risk factors and then you mitigate those side effects on thalidomide. Okay, so what happens is in REMS program, only registered physicians and pharmacists who are already registered with the REMS program, these are the only people who can prescribe thalidomide in US. Okay, no, not any physician can write thalidomide, only those who are registered with the REMS program. Okay, so you can, it's an online website, you can go and apply for registration, and only after obtaining registration you are free to prescribe thalidomide to your patients. REMS has standard consent forms and other forms for the patient and the doctors also. So you can give those consent forms to patients so that they can read it and sign it and be properly understandable. They understand all the risk involved, and then you can prescribe thalidomide. And REMS program lays a good stress on history, general physical examination, and neurological monitoring of the patient. Now REMS say that in monitoring you have to monitor monthly for first 3 months, then every 3 to 6 months, and this we are talking majorly about the neural side effects and the other side effects like thromboembolic events, drowsiness, everything. Monthly for the first 3 months, then every 3 to 6 months till they are on thalidomide therapy. SNAP measurement, sensory nerve action potential measurements every 6 months of therapy. Okay, so after every 6 months you have to look at the snap reduction, if there's any reduction in snap. If the reduction is more than 40% of baseline, you stop thalidomide. Okay, if the reduction is between 30 to 40%, you either decrease the dose or you stop thalidomide if you can. Okay, it's always a bit doubtful. You compare with the baseline snap measurement, that is pre-treatment snap measurement. If the reduction is more than 40, you have to stop thalidomide. Clear? Okay. So now we'll just revise this monitoring. Baseline, you have to tell all the drug risk, sign the consent form as per REMS. Okay, and the patient should give consent to participate in ongoing monitoring programs. In laboratory testing, you do pregnancy tests, serum or urine of adequate sensitivity, CBC with platelets, LFT, liver function test. In neurological, clinical examination is very important. And then they say to measure snap amplitudes from preferably two different nerves. Okay, and sometimes the REMS program also mentioned at least three different nerves should be used to measure SNAP so that you can have a baseline SNAP value, and if SNAP value decreases more than 40%, you have to stop thalidomide. Okay. Follow-up is for pregnancy test. It is weekly for the first 4 weeks, then monthly for women of childbearing age with regular menses, and if the menses are not regular, every 2 weeks. Okay, so it's weekly for 4 weeks, then monthly if the cycles are regular. If they're irregular, then 2 weeks. Okay, monthly CBC with platelet determination. Look at the platelet counts, and when the dose is stable, when the thalidomide dose is stable, so that you are not decreasing or increasing it, then every 2 to 3 months CBC is okay. LFT every 2 to 3 months. Neurological evaluation at least monthly for the first 3 months, thereafter every 1 to 6 months, which we have discussed in last slide. And SNAP measurement every 6 months or when clinically indicated. So this is monitoring guidelines. Just two important things in pregnancy: it is weekly for 4 weeks, then monthly for regular cycles, and two weekly for irregular cycles. And in neural evaluation, complete physical examination at monthly for 3 months, then every 3 to 6 months, unless clinically indicated. And the SNAP measurements is done every 6 months or if clinically indicated. Okay. Now, in pregnancy, again, nothing justifies the use of thalidomide in pregnant female. But if you really want to use, then effective birth control should start. If this is the therapy, okay, so this is the thalidomide therapy, then it should start 1 month before and should continue 1 month after. This is the duration of contraception. Okay, and the general guidelines remain the same. Two different methods, two different class of contraception. And remember that OCPs increases coagulation side effects, so you have to keep that in mind. Preferably barrier and IUDs are good. If you can totally abstain, then abstain. Okay. Before starting the thalidomide in females of childbearing age, a negative pregnancy test within last 24 hours of beginning therapy, then weekly for 4 weekly, then monthly if the cycles are regular. If they are not regular, then 2 weekly. Okay. Barrier protection is important. Now, this is, I think, the last slide of today's lecture. These are just the name of congeners who the next criteria or the next class of thalidomide congeners. And just because I wanted to include their name, if you want to know more about it, you can easily search in PubMed. You will find good articles comparing these drugs with thalidomide regarding its efficacy as an immunomodulator or even anti-emetic or sedative. Okay, so these include lenalidomide, pomalidomide, iberdomide, and avadomide. So just maybe a future, viva question of people who are interested more in quiz can, see this congeners for thalidomide. Clear? Okay, so with that, finally, after 2 weeks of hiatus, we are back with our evening lectures on leprosy drugs. We have covered dapsone, rifampicin, clofazimine previously, and this week we have finished with thalidomide. If you have any doubts, you can email me directly on my email ID. If there's any doubt, suggestions, any queries on how to make these lectures better, what more do you want me to focus on, what are your different suggestions regarding different class of drugs, just mention them in the comment section below. And I will take, if you have any doubts, if any new questions that have been asked to you about thalidomide or any other drugs that we have previously covered, you just mention that in your comment in the comment box, and we'll get back to you and answer that. In the meantime, we have other videos on the channel. We have covered immunomodulatory drugs like methotrexate, azathioprine. We have covered biologicals used in psoriasis. We have even covered the psoriasis guidelines, which are the JAD and the BGD guidelines for psoriasis. We have also covered etiopathogenesis psoriasis. And subsequently, every week we are going to discuss one important drug and other aspects in leprosy. Sorry, other aspects in dermatology. Now, just to share one anecdote, that I had a patient who had a history of kidney disease in the family and had intractable itching. uncontrollable itching, so much so that he was ready to scrape off his skin because of scratching. So he used to use all sorts of objects to scratch his skin off. And so much was the extent of involvement that he was covered from erosions head to toe. Okay, and those erosions were getting secondarily infected. I started cyclosporin, but the patient refused because there was history of kidney disease in the family. His sibling, you know, died because of kidney issues, so he didn't want to use any medication that has an impact on kidneys. We still started it, but the creatinine started to increase rapidly, so I had to stop cyclosporin. We started methotrexate, and he developed transaminitis in 2 weeks. Same reason we could not start azathioprine. Cyclophosphamide was initially started, but that led to severe secondary infection of the skin erosions. Steroids were started, which led to spiking of glucose more than 500, and it was managed only through regularly insulin infusion. And the impact of itching was so much so that the patient was just wanted to, didn't have the motivation to survive longer, and the skin was in shambles. It was in a very poor state, and I was treating him for atopic dermatitis or adult onset atopic dermatitis with significant intractable itching, not responding to 5 to 6 times the daily dose of antihistamine, along with pregabalin, along with gabapentin, along with SOS-based zolpidem. It was not at all improving. All the biopsies which were done keeping malignancies in mind came out to be typical biopsies. No atypicality was seen. The issue was just itching, and I was at loss of drugs. What else I could have done for him? So I contacted my faculty in my last institute and discussed this case with me. And one suggestion came up was thalidomide. So finally, from that instant onwards, I started thalidomide 400 milligram a day, 100 milligram 4 times a day, and within 2 days, itching got reduced to 10% of baseline value. And now I'm managing that patient on thalidomide. He's doing okay with decreased doses. He has to take thalidomide every third or fourth day, 100 milligram, but the itching is significantly under control. So after that, I started reading about thalidomide properly in detail, and it's one of the best drugs, one of the good drugs when you have to use it for inflammatory disorders. Just we need to be very, very, very careful about the side effect profile, and patient selection becomes very important. So we need to know these about thalidomide so that we can use it effectively. So again, before ending this presentation, I will again like to thank my brother who was responsible for getting me a good laptop so quickly, and setting up this PowerPoint recording feature so that I could make this video on time and able to upload it on YouTube. So if you're looking at this video, just say thank you to my brother. Okay. So with that, we'll finish this presentation. Adios. Hopefully the weather would be good this week. And let's end this presentation. We will meet again next week. And next week we are going to discuss second line drugs for leprosy. Okay, so we have discussed dapsone, rifampicin, clofazimine, thalidomide, and now we'll discuss second line drugs and how to treat leprosy in which you cannot use dapsone or rifampicin because of resistance or any other issues. We'll discuss second line management of leprosy. Okay, till then, bye bye, adios, and thank you.